work with the different groups that we work with in ensuring that collaborations are running smoothly and that everyone's on the same page in terms of the projects that we do. So in BC, that means helping to do a lot of the workshops and trainings that we've been involved in working with a lot of the folks on the phone with. April, maybe you can introduce yourself now, please.
Sure. I'm April Lawrence, also here at CCMI, and I'm a master trainer, which means that I deliver trainings in things like informed decision making or brief action planning or motivational interviewing, but I also train other people to become trainers to support the commitment to capacity building in the province and actually across Canada.
Thanks, April. And so we really appreciate you coming today, and we're looking forward to the opportunity to kind of work with you and talk through some of the ideas we have to share. The objectives for this webinar are to define person and family-centered care, define shared and informed decision-making, examine how values affect people's decisions, describe the spirit of motivational interviewing as a foundation for decision-making, and describe one way to support your patients to make decisions. I'll just talk a little bit around the different things that we'll hit in particular in the webinar. So first, we're going to place this webinar in the context of the Ministry of Health's 5 strategic priorities and talk a little bit about the triple aim. Second, we'll talk about the definition of person and family-centered care, as well as define shared and informed decision-making, so we all know what we mean when we talk about some key terms. Next, we'll examine how values guide people's decisions. And then we'll introduce you to something called the spirit of MI, which is one way to remember to provide person and family-centered services. Finally, we'll review the BRAIN worksheet. BRAIN is an acronym that we use to help the people we serve to make informed decisions. We'll learn about how to use that. The Ministry of Health has 5 strategic areas of focus, and this webinar is part of the work towards an overall improvement in the quality and sustainability of the BC health system. These quality improvements are both in experience of care and in better health. The focus is to work across those involved in healthcare in these 5 areas. Improve access to primary care through a primary care home model. Reduce demand on hospitals by improving care for seniors. Reduce demand on hospitals by improving care for those living with mental illness and substance use issues. Improve access to surgical services and procedures. Improve delivery of rural health services. Informed decision-making is an important aspect of each of these areas. For example, decisions about diagnostic tests and treatment options are made every day in primary care and need to be carefully considered in rural areas. Many decisions affect demand for hospitalization and access to surgical services. This presentation will consider how informed decision-making is an essential component of people's care. It affects care planning about chronic disease management and prevention and treatment decisions, and it's an important component to many healthcare provider and patient interactions. So developed by the Institute for Healthcare Improvement, these 3 goals, a better experience of care for both professionals and the people receiving services, and better health at a sustainable cost, have been called the triple aim. The triple aim approach has been widely accepted by healthcare, including patients as partners in BC. Clinicians can often see clearly how more informed decision-making can support the triple aim. When we ask clinicians what informed decision-making could do for their patients, they tell us it can reduce decisional regret, allow more informed decisions to be made about what is appropriate care, reduce unnecessary use of services, and improve how people feel about the care they choose to receive. So here are some of the core principles of patient-centered care. The Ministry's patient-centered care framework describes 4 core principles for patient-centered care that will be introduced at various parts in this presentation. They are dignity and respect, information sharing, participation, and collaboration. I'll talk a little bit about them now, but we'll share a little bit more later on in the presentation as well. Dignity and respect speaks to the need for active listening to patients and families and to honoring their choices and decisions. This is done through incorporating the patients' and families' values, their beliefs, and their cultural norms into care plans and care delivery. Information sharing is done through participative communication of timely, accurate, complete information with patients and families on what decisions are to be made and validating with the patients and their families what they have heard and understood. These are all the basis of this principle. This leads to supporting an informed decision by the patients and their families. Patients and families are encouraged and supported in participating in their care and in informed decision-making at a level at which they feel comfortable and of their own choice. That's how we talk about participation. In collaboration, finally, patients and families are provided meaningful opportunities to engage with providers and leaders in the continuum of quality improvement, policy and program development, as well as implementation and evaluation. This includes the potential for patient and family engagement. In the policy documents, the patient-centered care framework, the ministry says that patient-centered care puts a patient at the forefront of their health and care. Patient-centered care incorporates self-management support, shared and informed decision-making, an enhanced experience of care, improved information and understanding, advancement of prevention and health promotion activities. Informed decision-making is necessary to ensure patients and families retain control over their own choices and make informed decisions. Increased engagement in their care will support a partnership between individuals, families, and their healthcare service providers. So when we talk about this, all of the services that we provide and that are captured in these webinars, we talk about them through the step care management, the step care model for self-management support. And so as discussed in other webinars, self-management support can be stepped up to meet people's needs. Today's webinars address informed and shared decision-making, which is on the first step as an aspect of engagement to care. Everyone who encounters the health system deserves information and support they need to make an informed decision about the care they need and want. In a similar vein, again as mentioned in previous presentations, the General Practice Service Committee, a joint committee of Doctors of BC and the Ministry of Health, has presented a plan for co-creating the future of integrated care. This new plan for the patient medical home or primary care home provides support for patients and links with the specialized services and is consistent with the step care self-management support model. This pyramid is similar to the step care model in that people move up depending on their needs. So here's a version or a definition of patient and family-centered care developed by CCMI. It's guided by a person's values, strengths, ideas, and preferences in a compassionate and respectful partnership that makes certain that personal choice and informed decision-making shape how care is planned and delivered. It focuses on the person and their self-defined family to the degree that they choose. It's a plain language definition based on the principles and attitudes for patient and family-centered care. It's important to consider that the person and family-centered care is one aspect of quality. Care also needs to be safe, effective, equitable, timely, and efficient. I think this might be where April will be jumping in.
I left myself on mute. My apologies. It was a technological hiccup on my part. So there's another way to talk about patient-centered care that's sort of active in British Columbia. This definition is put forth by the Ministry of Health in 2015. Patient-centered care puts patients at the forefront of their health and care, ensures they retain control over their own choices, and helps them make informed decisions, and supports a partnership between individuals, families, and healthcare service providers. Patient-centered care incorporates the following key components: self-management, shared and informed decision-making, an enhanced experience of healthcare, improved information and understanding, and the activities of prevention and health promotion.
Thanks, April. So here we talked a little bit about the definition and the 4 principles earlier, and so here are the principles of person and family-centered care as developed for the Institute of Patient and Family-Centered Care and adopted in BC by the Ministry. The person is at the center, surrounded by their family and supports. All around them is a circle of 4 caring principles. We mentioned these previously, but here's more plain language definition. Respect and dignity. Helpers listen to and honor people and families, particularly their perspectives and choices. Knowledge, values, beliefs, and cultural backgrounds are incorporated into the planning and delivery of care. Information sharing. Helpers communicate and share complete and unbiased information with people and families in ways that are affirmed and useful. People and families receive timely, complete, and accurate information in order to be effectively participate in care and decision-making. People and families are encouraged and supported in participating in care and decision-making at the level they choose. And the final principle is collaboration. People and families are also included on an institution-wide basis. Leaders collaborate with people and families in policy and program development, implementation, and in evaluation. They also collaborate in things like facility design and in professional education, as well as in the delivery of care.
So here's a definition of informed decision-making for us to consider. A person's decision made knowing the pros or benefits and cons or risks of a decision while considering personal values. Decisions like these are required of us all the time, not just in relation to our healthcare. Someone can make an informed choice with very little involvement from others. Participative communication includes timely, accurate, and complete information. It includes talking with patients and families about what decisions should be made and validating the patients and families in terms of what they have heard and understood. All this can support an informed decision. Shared decision-making is a little different, and here's a definition of it. The process by which a person and an expert work together to identify the best course of action at this particular point in time. This is a decision made in a relationship with an expert. It could be your lawyer, your realtor, your financial advisor, your mechanic, or your surgeon. Working together includes sharing information. And the guide shares information about alternatives, and the person making the decision shares information about their values, preferences, past experience, and information they have gathered. There's a process of considering alternatives and the patient's own goals. The best course of action is arrived at by agreement between the two parties. The guide has to have time for the conversation and be prepared to share information in the way the patient can understand. The person has to be ready to participate and share their concerns. The result is confidence that the decision includes the best available research or evidence and advice, as well as the values and the preferences of the person. The measure of success is that the person walks away feeling they know their options, that the choice was the best under the circumstances, they're willing to give it a try, and report on the results of that decision. And the decision can be refined over time. So in order to make a decision, a person's decision about a healthcare test specifically, or a treatment which is voluntary, is based on their ability to choose. The ability to choose has 4 parts: having values and goals, understanding information, weighing options, and stating a choice. This is a technical definition from Sagan's Medical Dictionary. So essentially, possessing a set of values and goals, and understanding the information, and being able to deliberate, and being able to reason and state your choice are essential to making a decision.
Sorry, I caught myself on mute. Thanks, April. And so an analogy to kind of think about this is in thinking about the expert's role in making a decision. So one way to think about this is when you decorate a home, you can totally do it yourself. The decisions are all up to you, made by you, exactly how you want to do it. Or you could call in an interior designer who can help you design the room. Let's say it's a bedroom for a child, but if you don't confer with the designer about the things that are important to you, like color, ambiance, lighting, etc., you may get a very different product and potentially be very unhappy with the finished product, even if it's by a top designer. An effective helper is able to draw out from the person what they want and need in order to make the right decision for them. So for decision making, people can take a DIY or a do-it-yourself approach, and this promotes autonomy in the person's expertise. Or they may choose to hire someone to help them with their decision, as long as that person takes the time to get to know them and is constantly checking in with the person to ensure that they know what their goals are to ensure a good result.
So here's another way to think about that. Imagine you're in the cereal aisle of a very large supermarket, and there are many, many cereals to choose from. There are so many choices. What's the most important factor when you are buying your cereal? What makes a difference when you're buying it, and what matters to you? When we've talked to other people across British Columbia in the past, they said things like they look for sugar content, fiber content, organic ingredients, price, is it on sale, if they know their kids will eat it without making a fuss. But there are values behind those factors. If sugar or fiber is the main factor, then when you think of the value behind it, it's probably health. If it's organic content, then the value could be health again or environmental protection. If it's price or whether the cereal is or isn't on sale, the value might be frugality or financial responsibility. Worrying about a fight at the breakfast table might be informed by the value of family harmony.
And cereal is a great example. Now imagine you have chronic pain that interferes with your daily life, and there is a surgical procedure that has a 50-50 chance of relieving some or most of your pain. There is a 10% chance that it will make your pain worse, and a 40% chance that there will be no change at all. What's the most important factor to you when considering the surgery? Just take a moment. I would invite you to take a moment to think about what factors may be important to you and why. We have heard from participants in the past that factors that weigh in for them are things like the experience level of the surgeon, just how bad the pain is now, how long the recovery is, how much time they will need to take off work, how much help they will need at home during recovery, or what the alternatives are. Sometimes it can be tricky to tease out the value that informs each factor, but the value is there. They could be things like orientation towards risk, family function, financial responsibility, perhaps family responsibility. It could be a value for informed decision-making and understanding alternatives. Sometimes the same factor can be informed by different values in different people. Imagine a concern about how much time you'll need to take off work in order to get the surgery done. We can't assume that the value behind that is similar. It could be about a value providing for a family, or it could be a value around orientation to your career. Some values that may come up are functioning, orientation towards risk, evidence-based decisions, knowledge about alternatives.
So here are some examples where an informed choice might be a better one. Some you might be able to imagine your patients and clients making, and some you might be able to see yourself making. Imagine what you would want for yourself in these decisions. So motivational interviewing is a collaborative conversation style to strengthen a person's own motivation and commitment to change. We're not going to talk about motivational interviewing in depth today, but this underlying spirit of motivational interviewing is very useful when considering decision-making or how to help another person. You heard about the spirit last week in the webinar on engagement. The spirit of motivational interviewing is described by Miller and Rolnick, the founders and researchers who established motivational interviewing. There are 4 things that make up the spirit of motivational interviewing: compassion, acceptance, partnership, and evocation. It's been shown in studies that when helpers demonstrate the spirit of motivational interviewing in their interactions, people they're working with are more likely to change. Let's look at each part in detail. First is compassion, caring about what's important to another person and feeling moved to help. This interaction is done with heart. It's very different than convincing someone to do what you think is important for them. Receiving compassionate care is linked to greater satisfaction with care.
Acceptance means you respect the other person and their right to change or not. It does not mean you have to agree with their behavior or their beliefs. People who are competent have the right to make choices. Sometimes you might find these choices puzzling, but it's not our place to decide what is right for another person. We can help people make choices that better fit their goals, not our goals as the helper or clinician. Sometimes, as clinicians, we do work with people whose competence to make decisions is compromised. We aren't talking about that situation here. But even in those situations, respecting autonomy as much as possible is still important. Partnership. Partnership is working together with another person and recognizing them as an equal. Avoid the expert role as clinician. Recognizing people have expertise about themselves. MI is not done to or on someone, but it's done with a person. Evocation means bringing out another's strengths and knowledge about the situation and themselves. Another way to think about it is to encourage to explore. People already have within them much of what is needed. Our task is to evoke or call it forth. The ideas come from the person, and our job is to help draw them out. Adults mostly don't like being told what to do in their personal lives. Most people's initial reaction to being told what to do is to put up some resistance. For example, studies in alcohol treatment have shown that clients working with counselors who are directive and they talk less about change, and they're more resistant to change moving on. April, I'm not sure if you're muted.
Sorry, all that was delivered beautifully on mute. My apologies, everyone. We've had the opportunity to work in many communities across British Columbia, and these are the answers other participants have given us about how the spirit of MI can support informed decision-making. Exploring or evoking can ensure that the patient's values are heard and understood. Partnership can allow the patient to be an expert in their own life. Acceptance helps both the clinician and the patient feel okay about the decision that was made. And compassion creates the space for honesty about values and preferences. So it's all very easy to talk about being patient-centered and supporting informed decision-making, but these principles can be hard to put into action. Here's a worksheet that CCMI uses to help clinicians implement these principles. You can download it from the website after attending the webinar. CCMI first learned about the BRAIN acronym from a family member who was attending a childbirth education class. For over 2 years, CCMI tried to find the person who first used the acronym, but without success. If you have any additional information, please let us know. CCMI did obtain permission from the International Childbirth Educator Association to adapt it for wider use. Here's the scenario in which informed decision-making may be helpful. Sometimes informed decision-making is just about giving the person time to sort through the information they have, figure out what additional information they need, and plan for their next steps. So Doug and I, that's a photo of us, are preparing to marry, and there's a lot of paperwork happening anyway. Is this the time to restart a stalled conversation about getting through an advanced care planning directives for both of us? While there are other documents that support end-of-life planning in British Columbia, this is the one we really need to talk about.
So April and I are going to do a little bit of a role play, and I'll be asking her some questions around this, as someone might do working with a client or patient with the BRAIN worksheet. So remember, your role in using the worksheet is to encourage the person to answer the questions from their point of view. If they ask for information or advice, or you ask permission to give information or advice, that might be helpful to them. Sometimes your role will be to sit back and just let them sort things out. What are my values? Is the conversation about what really matters to the person making the decision. Is it comfort, length of treatment or length of life, a daily activity, time with family or friends, a goal they want to accomplish? Often there will be values in conflict with each other, such as quality of life versus family responsibility. Values in conflict is what makes a decision difficult. So April and I are going to talk through her situation.
Well, the decision I need to...
Maybe I probably jumped ahead too quickly. I'll just ask you these questions. I think that we've addressed what decision is that you need to make. Maybe you can talk a little bit more about that, and then maybe the time as well.
Sure. I need to decide whether or not to open up this conversation again about an advanced directive between my fiance and I. And we might not be able to finish the document before we get married in December. I doubt we can. But I'd at least like by December to know what our plan is. I'm involved in making this decision, and so is my fiance, obviously. My values are in conflict. I know this is a difficult conversation for Doug, although it's not for me. So my value of harmony in our relationship is kind of in conflict with my value believing that advanced care planning is a responsible and important thing to do, that values relationships and shows respect for one another.
Thank you. I just wonder, are there any other people that might be involved either as knowing about the result of the decision, like siblings or parents or anybody else that might be involved?
Oh, that's a really good point. Doug is the youngest of 5 children, and his parents are both gone. So, yeah, his brothers and sisters would be the people who I might find myself in conflict with if something were to happen to Doug. And so while they might not be involved in making the decision, they certainly are people we need to consider.
Thanks. So the next part of the worksheet asks to get a better understanding, or seeks to get a better understanding of the benefits that the person might face with this decision. And so I'm wondering, from your perspective, April, what are the benefits of advanced care planning directives?
Well, for the benefit for me would be peace of mind, knowing that that I know both that I know the right thing to do for Doug, should I ever have to, and also knowing that someone else, because I don't have brothers and sisters, knowing that someone else knows what I want, so it's peace of mind in both ways for me. I see the benefit for those close to me as an advance directive means that the kind of responsibility for a really terrible decision is lifted off of Doug if something horrible were to happen to me. What he is to do or not do is already clear for him. So I think it's sort of an easier course of action in what would already be a terrible time. And that's how I see the benefits.
Thanks. I wonder if you can talk a little bit about some of the potential risks.
Sure. The big risk to me is a source of discord in the house, is that the conversation goes badly and that it sows discord. And that's kind of why it died the first time. We started talking about it and we stopped because it was too difficult. And so that household discourse is the biggest risk to me. I think the biggest risk to Doug is if something terrible happens and he doesn't know what to do and isn't clear on what to do. I see that as a substantial risk. I guess there's also risks to the emotional comfort of his family and his brothers and sisters that we have to kind of have a plan to deal with if we go ahead.
Mm-hmm. I think it's important to highlight here, we're talking about the risk to you, but you're also identifying the risk to other people. And that might change over time. People may be more or less involved. And you might change your mind, even a week from now, you might decide the risks are slightly different or the benefits are slightly different as we go. And so it's kind of an organic thing that can change as we go through the process of looking at this.
Absolutely.
And so the third part of the BRAIN acronym, alternatives, seeks to understand any other options, in the short or the long term. So alternative choices, do you have the option to do nothing? Are there other ideas, that might take the place of the decision you're trying to make? So April, what do you think about alternatives?
Well, do nothing is the alternative we've been doing now, which kind of is increasingly uncomfortable for me. It's not working for me. I suppose an alternative would be that I've been thinking of this in terms of do we both have an advance directive? Maybe I could just have one. Maybe one alternative would just be for me to finish mine and not make it dependent on both of us doing them. That's probably an alternative. I guess we could also use, instead of starting from scratch, we could try to use documents that might make it a more neutral or supported conversation. So I could seek out different documentations, or I could just plow ahead with mine, feel like my two alternatives.
Yeah, thanks for sharing that. I think it's insightful to know that, one or more people might be involved in the result, but it could just be something that you do on your own. And so the last question, I guess the second to last question, but the one that I think is really important in telling of how people's values come together and may or may not show conflict or clarity or confirmation. How do you feel about the options, or what does your intuition or your gut say?
Well, my intuition says that involving Doug's extended family too soon will make our process harder. So I appreciate that they are part of this, but I think we need to get our own house in order before we bring in his brothers and sisters. And so that, I think, is important. And we have excellent communication and a really respectful relationship. And so my intuition is that we can have this conversation if we find the right way to do it. So I think it's worth pursuing.
And the trick is next steps. So the last piece is sort of working with your peer, client, helper, and talking about what you'd like to do. So it sounds like you have a pretty good idea of what you'd like to do, although you might be feeling a little bit ambivalent overall. Do you want to talk about what your next steps might be?
Yeah, I think my next step is to start doing my own, to finish my own advance directive, which is further advanced, and be open about why I'm doing it and the benefits I see, and kind of put the request before Doug that I would appreciate it if he would do this too, but that I'm not going to insist on it. I'm going to try to set a good example and lay the foundation for a conversation about it. I think if I show that the paperwork isn't that frightening, I think if I sort of provide a model for having that dialogue with myself. He's also a very curious person, so I think if I just do my own, which then fulfills half of the benefits that I can provide, the responsibility. I can be honest about my values of responsibility and provide him the benefit of knowing what to do if he needs to. So it kind of gets half my mission accomplished. So yeah, I think my next step is to just do mine.
Thanks. I think that's really clear, and it I think provides a good example of how people might have mixed ideas or understandings of what next steps are in a relationship. And this could be a caregiver and a patient, or it could be a family member, or in this case two folks that are looking at planning their future, and that's okay. But having a tool like this enables a conversation which potentially leads to some more clarified next steps, like we talked about before, reducing decisional regret, allowing people to make more informed decisions and to feel more confident in their choices about care and future process and steps. So, as we just showed, the final part of the worksheet asks a person to commit to making a decision. Remember, the decision might be to gather more information, or it might be to do nothing. Doing nothing is a decision. For those of you who know about brief action planning or another planning method, the next step after the decision might become an action plan. Things like where, when, how may be helpful things to discuss. So April and I could have talked about that. Thank you for sharing your thoughts with us today, April. We could have talked about goals for your action or for your advanced directives moving forward.
So here are some things to remember to ensure your assistance is consistent with the spirit of motivational interviewing as we talked about them earlier. First, always emphasize choice and options. Provide any idea you give as a possible choice, not as the right way to do things. For example, you could say, after you've gotten permission, one thing the other people in this situation do is this. Perhaps that might also work for you. Instead of just giving one idea, you could give several. Sometimes people in your situation decide to do X, Y, or Z. Maybe one of these is right for you, or you might have an additional choice that makes the most sense. It's consistent with the spirit of motivational interviewing. It demonstrates acceptance of autonomy and partnership. Secondly, remember, this is their document to fill out. It's not your document to fill out for them. They should be holding it and writing on it. It's not a place to write down your perception of the benefits. It's to help them find their own. So third, support the time it takes. Some decisions can wait for a while. Don't rush. If a decision is in a moment of crisis, then obviously it's different, but most decisions has a little bit of time. Fourth, it's important to understand that this can actually be a do-it-yourself document. People can fill this out without you. You can send it away with them. And so if they need information you cannot provide, help them figure out options to find out the information that they want or need, or give them any information that you have. Lastly, if you know this information, use plain language. Imagine the words that people might use in their living room. We'll talk about this more in the upcoming health literacy webinar. Use pictures or figures if you can. If the person asks questions and you know the answer, consider drawing or writing down key points, and consider that. Make sure your language is as free of jargon as possible, or you explain your terms. So let's review what we did today. First, we placed this content within the context of the Ministry of Health's 5 strategic priorities and talked about the triple aim. Secondly, we talked about a definition of person and family-centered care, as well as the difference between shared and informed decision-making. We examined how values can guide people's decisions. We introduced you to something called the spirit of MI, which is one way to remember to provide person and family-centered services. And then we reviewed the BRAIN worksheet, which you can download from the CCMI website after this webinar. This webinar is part of a series about self-management support. Informed and shared decision-making is one part of engagement, which is a first step in self-management support. Other parts of the first step are working in diversity and ensuring health literacy, Health literacy is the topic of the next webinar. Later in the series, we'll talk about ways to help people make plans using the information they have. One example is brief action planning. The third step builds on others, and some possibilities of this step are motivational interviewing, which will be introduced in a little more depth later in this webinar series.
Thanks, April. And I think now we're able to open the floor. If people have questions, we welcome or invite you to chat them in to your chat box, and we have a little bit of time to respond to questions before talking a little bit about next week's webinar. And Vern, someone's asked about going back to the list of examples where the brain worksheet would be useful. If you like, I have your name here. I can send you an email with that, but I don't know if there's specific things you want to speak to, April, on that.
What the question? Only one of us can see the questions. So the question is about what sort of situation would be supported by the brain's worksheet?
Yeah, some examples. Maybe just talk a little bit about examples that are useful.
Sure. Well, if you can imagine this being applicable in almost any situation, a decision about whether or not to continue on with treatment, whether or not to accept treatment, whether to accept home care into your house or not. You might want to give this to your older teenagers when they start to decide whether or not they might go to university. It's actually a tool to help people think through any decision that is perhaps complicated. It gives an opportunity to break that decision down into parts and explore the values that inform your decision. Any decision more complex than which sandwich for lunch would actually benefit from something like this. So I think once you start looking at patients and clients in terms of what decisions you're asking them to make, you'll start to see really quickly the opportunities to use this in your practice or perhaps even in your life in general. I give this worksheet out liberally to almost everyone I know making a decision about whether or not to change a job or whether or not to do anything. Thanks.
The next question I can answer pretty straightforwardly. Are you able to get an electronic copy of the brain worksheet? Yes. In the email that Troy's going to send out after this, we will, probably later on this afternoon or tomorrow, there will be a link to our informed decision-making page where you can download the worksheet. It's in the PDF form. As well, we have kind of a fancier trifold version, which we haven't shared on the webinar, but if anybody's interested, they're just a bit nicer rack card style, and we're happy to share the print proofs with you, but you would have to have them printed yourself. But the PDF, by all means, can be downloaded and shared, as you wish with anyone that you think might benefit from it.
And Sam,
the next question, April.
Oh, sorry, I was going to say, you can let me know if I'm right or wrong about this. There were 2 versions of this handout on our website. Are there still 2 versions?
I believe there is only one.
Okay, perfect. I just wanted to make sure that if we hadn't reduced it to 1, we weren't confusing people. Perfect. Sam, you said there was another question.
Yeah, the next question is, are you able to divert from the brain worksheet if the conversation takes you in a different direction?
Oh, I would say, of course. This is a guide to a conversation, not a sort of an ironclad thing you must accomplish. These tools are designed to be helpful. If a tool stops being helpful or something else is obviously more helpful, then by all means, divert. It's respectful to the principles of patient and family-centered care if it's your decision to divert, that you talk about it and your reasons why with the person that you're working with and see if they agree. If someone who you're walking through this worksheet with suddenly realizes they need to have a completely different conversation with you first, then by all means. But if you have, in talking about things with them, uncovered something that you think needs to be addressed as a professional, always be transparent. Don't, because they might prefer to finish this conversation and then have the one you want to have, or they might agree to stop right there in the middle and talk about what you want to. Just always remember to put patient goals and values at the center of this.
Thank you. I think that's very clear, April. I don't see any other questions, so I might just talk a little bit about next steps and the next webinar. As questions come in, we can bring them up. Well, here's a good question specifically about your example, April. Does the brain worksheet allow for cultural aspects to a conversation in advance directives? It means like informed consent, informed decision will depend on the culture and openness to informing the patient about the situation, even if it's not aligned with their belief. So how would you talk a little bit about that?
Well, let me make sure I understand the question first. So if you're speaking across cultural barriers, and I'm assuming that the situation here might be that you as a professional feel that you want to have a conversation and you would like to tell your patient and their family as much information as possible, and there's perhaps resistance to that information. Then putting the person's values and what they want to know and wish to know at the center is the spirit of motivational interviewing. So it needs to be their agenda, not yours. It can help to send people away with this document and allow them to sort it through in their own context, to be as respectful as possible, or even just having a curious conversation about why they would prefer not to could help inform you. CCMI does some beautiful work and some training around working across diversity, which means that, and the way we present it, is that you can't necessarily assume that the person across from you has a certain set of values and preferences based simply on their visible ethnicity. I know a lot of people who look an awful lot like me who really, really are wildly uncomfortable talking about advanced directives, like my fiance, for example. And a lot of people who don't look like me who are quite comfortable having these conversations. So it's always going to be about finding out what the value, comfort, desire to know information, and willingness is of the person across from you, which might not be remotely helpful, except to know that you might wish to get in touch with CCMI because we do have sort of tools and approaches that might be of more assistance to you.
Thanks. The next question is, would you recommend giving the worksheet to patients? And yeah, absolutely. I think that it's a tool that you can use either in a partnership or individually. So a patient might benefit from taking it home and thinking about it with their family or by themselves. Or you might have time in an office visit or in a clinic visit or just speaking with someone to go through some of it together, all of it together, or a portion of it, and allow them the opportunity to start thinking in this way. I think down the road eventually you want to build the skill and the capacity that they wouldn't have to use the worksheet in future, although they might use it as a way to kind of key their memory. They would start thinking about their care in these ways all the time and having conversations and seeking information to ensure that they were as clear as they wanted to be moving forward.
Depending on the complexity of the situation, the only part that it might be important for you to be engaged in is making sure that people do actually understand the decision that they're making. And sometimes healthcare can be incredibly confusing, and we can actually not be terribly clear about the decision that we're making. Once people know that, there's an enormous amount they can do on their own, and if they realize suddenly they have no idea what their alternatives are when they get to that section of the worksheet, they'll return to you for more information.
I'll just wait one more minute for any other questions that might be coming, and then we'll jump on to next steps. I think I just want to sort of reaffirm and kind of encourage people that the skills discussed in this webinar are really like any other skill. They require practice and feedback. So we encourage you to learn more about them by contacting your patients as partners lead in your health authority or in the ministry, and by contacting CCMI. We really would like to hear from you with questions, how it might work in your practice area, success stories and challenges, because those help inform the pieces of work that we do and make our services and make the way that we move forward better for British Columbians in general. And just do an advertisement for next week's webinar on September 7th. We will be sharing about health literacy. Some of this will be relevant to people that are helping to inform other informed or shared and informed decisions as well, helping to speak in plain language, sharing concrete written materials, those sorts of things. So Marianne Waters and Connie Davis will be talking about health literacy next week, so I would encourage you to join us for that webinar as well. And after this webinar, you will receive a survey, and so we would really appreciate any kind of feedback you have in your participation in order to help us to understand what we're doing well and what we could improve in these webinars and in the work that we do. And lastly, I would just like to say thank you very much for joining us. There's an email address there. You can shoot us any questions that you might have. As well, Troy will be sending you all a follow-up email, and you can follow up with him with any other questions that you have, and we'll be sure to get back to you as soon as possible. There's one final question, and it comes from, again, on that cultural diversity piece. If we want to change the tool to fit better with the culture of our clients, is that okay? And I think that from our perspective, this is, like April outlined, this is a tool that it's sort of a jumping off point for conversations. If you identify that there is something about it that could be improved or changed to work with a specific population, we would love to hear about that. The one that we have was adapted from early childcare. We worked with a number of patients as partners from the Patient Voices Network to design the tool that we work with today. And if there are different contexts in which it might be modified to improve the experience of the people using it, we would definitely love to hear about that.
I guess my 2 cents there would be this worksheet was developed in conjunction with a number of patient partners over a fairly extended period of time. So if you were going to change it, we would just encourage you to do the same, to take a few representatives of the group you think it needs to be modified to fix, and speak to them about whether you're on track about the modifications or whether they see a way to make it more effective. So because it was developed in conjunction with patient partnership, we would encourage you to modify it in the same way.
A very good point. Thank you, April. And with that, I think we will wish you all a lovely afternoon and see you next week for our health literacy webinar.
Thank you, everybody.
Bye.